All right, we're going to go ahead and get started. Sorry about that. I thought my mic was on, and it was not on. So first order of business, is there any bill introductions? Representative Epley.
Thank you, Madam Chair. I would like to introduce to the committee for consideration of a bill number RS-0505, which is an act enacting the Patient Right to Visitation Act relating to hospitals, adult care homes, and hospice facilities requiring in-person visitation in certain circumstances.
Any other bill requests? What do you need? On behalf of whom?
This is on behalf of myself and Representative Ressman.
Yep. Yeah, they still become a committee bill. It's just part of our process to know who it is that made the request, because we don't have individuals introducing bills. So you'll notice some of you have been asked to introduce bills, which means then you get to call Scott and ask Scott to write it up. Then Scott gives it back to you. You introduce it here, but then you have to tell us, was it on behalf of Representative Epley and his crew? So it just lets us know where the bill came from. Any other questions on that? Okay. All right, committee. Our first order of business is we're going to have a presentation from the silver-haired legislature. So I'll recognize Randall Hardy right now to committee. Welcome to committee, Randall. Been a while.
Thank you, Madam Chair. It has been a while. This is fun to be back in the legislature this morning and now. Welcome. Thank you for having me, committee members. My name is Randall Hardy again. I was former state senator here, and so I spent 4 years, great years of my life, doing good work for the state of Kansas. And now I am the speaker for the silver-haired legislature, and I represent that group during the legislative session. I appreciate this opportunity to talk with you a little bit, to get you acquainted with silver-haired legislature and its purpose in the state of Kansas. The silver-haired legislature initially was organized by an act of Congress back in 1969, and Congress then encouraged each state to enact their own state version of the silver-haired legislature, so that seniors could be represented in an effective way in the state legislatures. And so the Kansas Silver-Haired Legislature then was created by Kansas Senate Concurrent Resolution number 1649, which was passed in 1982. So we're just over 40 years old now, and have been an active part of the legislative process since that point. Anyone that reaches the age of 60 is eligible to represent their county in as part of the silver-haired legislature. We have 125 members. We're a unicameral organization, and we mirror the House process in the state of Kansas. So each county has a member representing their county, and then 4 counties, Johnson, Wyandotte, Shawnee, and Sedgwick, have 5 additional members each because of the population there. So we work throughout the year to gather concerns and priorities from the senior population of Kansas, and then throughout the year we'll meet periodically to determine what our priorities should be. We are, going back for a second, we're not really an arm of KDADS, but we are associated with KDADS. We have a little cubby hole over in KDADS that we can work out of when we need to. And we are also related to the 11 area agencies on aging, and that's how we are represented. We divide ourselves into 11 groups throughout the state, and then we meet as those groups, and then we come together in Topeka in the late month of part of the October and early part of November to actually meet in the House chamber. We have committee meetings with hearings, and we've actually had some lobbyists represent points of view on various issues. So we operate a lot like the Kansas legislature, and specifically the House, when we meet and conduct our business. We'd also have access to research and revisers when we are in the preparation process for our resolutions. We have 6 resolutions that we are coming to the legislature with this session, and those will be implemented probably during the course of next week. And so the that is those resolutions represent the result of our fact-finding process throughout the state. So we are we provide the process of what we do. We are the advocate for the Silverhead Legislature in Kansas, and we provide information to each of the legislators during the course of the session according to what our priorities are. We will testify periodically at hearings held during the legislative session, and we'll either be proponents for bills, or we may be have our own resolutions or bills that we'll be testifying for as well. Then we will meet also with seniors in county and district about legislation affecting older seniors. The Silverhead Legislature is not funded by the states. We are funded primarily by various groups like county commissions. We receive some of our funding by volunteers, and the contributions that we receive are tax deductible. We are a 501c3 organization, and so we're more of an education arm. We're not really a lobbyist arm. When we make presentations and when we chat with the legislators. We represent approximately 670,000 senior citizens in the state. That's people don't think about a segment of the population like that, but the population of Kansas 60 and over is a rather large population, and so it's important that the voices of those seniors are heard in the State House. And we will be, that's why we're here. We're going to be talking about those issues during the course of this legislative session. When we met here in Topeka the last part of last year, we developed 6 issues that we would consider our major priorities for this legislative session. And we would hope that you would, when the time comes to consider legislation that either includes these resolutions or are identified by these resolutions, that you would consider them. The first resolution considers the need to support the expansion of Medicaid in Kansas. And I know when I was in the Senate, it never went anywhere. And so I don't know, keep my fingers crossed. But the part that I would like for you to know is that of that group of 155,000 people that fall into that category that would benefit by Medicaid expansion, there are 16,000 people between the ages of 60 and 65 that would also benefit from that program if it was available to them. Another resolution we have would support the funding of collaborative community-based transportation for senior citizens. I know in Salina we have something called City Go buses that go all over the town, but now they also go from Salina to Minneapolis and Concordia and Belleville, making that loop so people, in a large degree, seniors will have access to the medical community and shopping and those sorts of things. We would also urge the legislature to provide increased funding for wireless broadband, which is something that is needed badly, especially in the rural and western parts of the state. There are a lot of senior citizens that would benefit by having telemedicine available to them so that they can have quality health care while not leaving their homes. And they don't have that right now to a large degree. We would also urge the legislature to legalize the expanded use of cannabis. There are many seniors out there that are in pretty much a constant state of pain, and there are a lot of those seniors that are leery about becoming addicted to opioids and other forms of medicine, but they find relief by having access to cannabis, and so we think that would be a good thing to have for that population. We would urge the legislature to maintain the current funding for the Senior Care Act and keep current statutory eligibility requirements. The Kansas Care Act, Senior Care Act, is a wonderful program, and we're lucky to have it in the state of Kansas. It provides needed funding for seniors who can stay at home if they have a little help, someone to come in and check on them and maybe straighten the house and make sure that the living conditions are safe and clean for these people. And it's much cheaper to have the people living at home where they are happiest rather than having them have to go to some other health care facility. We would also urge the legislature to support, we have a special request. We have 11 area agencies on aging, as I mentioned. 3 of them have a sales tax exemption, and 8 do not. And it's the 3 largest ones that have that sales tax exemption. We would like to have all 11 have a state sales tax exemption if possible. These priorities will benefit the state and the older Kansans and every Kansan really can benefit from a lot of these resolutions. As a former member of the legislature, I understand the challenges and the difficulties in passing any kind of legislation, and I am happy and willing to testify in support of any of these measures, and I will look forward to working with your committee and other committees so that some of these resolutions perhaps can indeed become law. I appreciate this opportunity to share with you my thoughts on Kansas Silverhead Legislature, and I'm happy to stand for questions at the appropriate time.
Thank you very much, Randall. Committee, are there questions for him? No one? You must have done a great job in explaining things. So, Randall, when you talk about that there's funding for the Silverhead Legislature, does that mean that someone gets paid or they all get paid, or what's the funding for?
It's a totally volunteer organization. When we participate in our activities, we're on our own dime. Now, what we've changed, one thing that we have changed is that the speaker, which is me and one other officer, when we drive here, we will be reimbursed for our mileage, but that's about all. I'm here out of the kindness of my heart.
Okay. Well, there's nothing wrong with that. We do have a few organizations that do that as well. So, okay, once again, committee, any questions for Randall? All right, seeing none, thank you very much for coming here today and giving your presentation.
Thank you. I appreciate the time.
All right, next committee, we have Statewide Addiction Prevention, Chrissy Mayer, Chief Community-Based Services Officer for DECA. Welcome to committee.
Hi, thanks. Glad for some time, and I think I have a PowerPoint that's going to pop up here. Okay, good to go. All right. Well, thank you again for allowing some time for me to speak about this topic. Prevention services often doesn't get a lot of floor time, so it's exciting to be able to share some information about what we're doing and what we could do with additional resources. So my name is Chrissy Mayer, and I'm the Chief Community-Based Services Officer at DECA. In this role, I manage multiple prevention programs across the state. So today I'm going to talk a little bit about 3 primary pieces. The first component will highlight prevention coalitions across the state and how DECA supports coalition efforts with evidence-based programs, policies, and procedures. Next, I'll highlight the naloxone program that DECA operates with funding provided by KDADS. I'll also touch on fentanyl test strips as a low-cost harm reduction tool that can be used with naloxone to save lives of Kansans who may unintentionally ingest fentanyl. And finally, I'll tie these pieces together across the continuum of care with a cost-benefit analysis. DECA provides services to more than 80 community coalitions across Kansas. We have a team of 5 specially trained community support specialists who provide training and technical assistance to these coalitions. On this map, you'll see 5 service areas. The colors designate the areas the community support specialist serves. Staff are located in these areas and are familiar with the unique needs within each area of the state. You'll also notice some stars and circles in certain counties. These symbols designate coalitions that receive either state funding through the block grant or coalitions that receive federal funding through the Drug-Free Communities Program, or the DFC project. There are currently 13 coalitions in Kansas funded through a competitive grant application process through KDADS, and 9 coalitions funded through federal DFC dollars. The circles represent KDADS-funded coalitions, and the stars represent DFC coalitions. DECA facilitates a DFC coalition located in Douglas County called Engage Douglas County. This coalition will receive 1 of 3 National Coalition Awards for Effective Prevention Outcomes next week in Washington, D.C. This is the first time a coalition from Kansas has received national recognition from the Community Anti-Drug Coalitions of America. This next map shows all the coalitions in Kansas, including the funded coalitions shown on the previous map. Some coalitions may be physically located in one county, but serve multiple surrounding counties. We see this more frequently in the western half of the state, where some agencies may represent multiple counties. In this example, you'll see in the northwest corner, there's actually one coalition that serves 8 counties in that area, but they're only designated with 1 marker. New coalitions are regularly formed in response to community needs. The DECA team has a vast library of resources designed to help individuals form coalitions to meet community needs. DECA is also a member of the Kansas Prevention Collaborative, including partners at Greenbush, Wichita State University Community Engagement Institute, Kansas Suicide Prevention Headquarters, and KU Center for Community Health and Development. All partners play a unique role in the Kansas prevention system, ensuring a coordinated network is available for communities to access. So why are coalitions an important piece of community? Coalitions address the root cause of problem behaviors. They implement evidence-based programs, policies, and practices that address identified issues. In this graphic, you'll see that the branches are the symptoms of the problem. There are many programs available once youth start exhibiting symptoms of a problem. However, these programs don't necessarily address the root cause. If we don't address the root cause of problem behavior, the symptoms continue. Root causes vary from community to community. Coalitions utilize data to analyze the issues and determine how to best move forward to address the root cause of symptoms they are seeing. Effective coalitions represent multiple community sectors. Engaging multiple sectors can diversify coalition work, ensuring that multiple perspectives are heard. SAMHSA encourages communities to engage these 12 core sectors initially when forming or reviving a coalition. Coalitions utilize the Strategic Prevention Framework, or SPIF, to guide their prevention efforts. It is an evidence-based planning model from SAMHSA that contains 5 specific steps. When utilizing this model, coalitions are more effective in their prevention efforts. And this is the model that DECA uses to train all our coalitions in this work. The first step of the SPIF is the assessment. During this step, coalitions identify the needs of their community and readiness resources. Next is capacity building. During this step, coalition members engage other stakeholders and raise awareness about needs in their community. During planning, coalitions implement evidence-based research evidence-based strategies and develop a strategic plan with measurable outcomes to address identified challenges. During implementation, coalitions implement the strategies identified during planning. In evaluations, coalitions assess if what they are implementing is meeting the anticipated outcomes. Throughout the SPIF, coalitions are mindful of cultural competence and sustainability. They strive to ensure that the strategies implemented are sensitive to the culture of the community and consider which components should be sustained and how that can happen. DECA believes that local people solve local problems. Our goal is to provide training and technical assistance to coalitions to do the work independently. Initially, we assess community coalitions to determine necessary supports. We develop training and technical assistance plans tailored to individual communities, which allows us to build the capacity of community coalitions to implement a comprehensive prevention plan. Additionally, we offer a variety of on-demand virtual resources that can be accessed through our website. As part of our training component, we currently have funds to provide mental health first aid free of charge across Kansas through ARPA dollars from KDADS. This training teaches individuals how to identify, understand, and respond to signs of mental illness and substance use disorders. We offer youth mental health first aid designed for adults working with youth and general mental health first aid. We also are offering instructor trainings, which will increase the number of trained instructors in Kansas available to teach the course. DECA will begin a pilot project in April in collaboration with KSDE focused on educators. Through this pilot, we will facilitate a youth mental health first aid session and facilitate a community of practice, providing school-based personnel an opportunity to build their skills related to youth mental health needs. Let's transition a bit now to our naloxone and overdose prevention work. As you are well aware, the opioid crisis has grown significantly in our state over the past several years. This issue is not unique to Kansas. One tool we are using to address the crisis is naloxone. Naloxone is an opioid overdose reversal medication. Naloxone is the same as what you may have heard referred to as Narcan or Kloxxado. Those are just simply the name brand versus naloxone, which is the name of the medication. Naloxone will not hurt someone who isn't on an opioid. It won't have any effect on anyone that is not currently using an opioid. This means that naloxone is safe to use on children and even dogs. The dosage is the same for everyone. Naloxone works in 1 to 3 minutes and lasts for 30 to 90 minutes, allowing time for a life to be saved. DECA has operated the Kansas Naloxone program since August of 2020. Since that time, we have provided more than 24,000 kits to individuals and organizations in our state. This program is funded by state opioid response dollars through KDADS. At various times, we have operated a wait list, unable to provide this product due to lack of funds. Our most recent wait list ran from September of 2022 through December. In January, we began sending kits to communities again. We also provide training on overdose prevention and naloxone administration. Training can be requested through DECA's website at free of charge. While we don't always know what happened with the naloxone we provide, we do ask for additional information when someone requests a second kit. Through this query, we are able to determine that more than 140 Kansans have been saved through this product. This is someone's parent, someone's child, someone's sibling. This next map, I sure do have a lot of maps here. This next map will illustrate the number of kits provided to each county from October of 2020 through September of 2021. You can see that many counties were touched throughout this project. The next slide will show the number of kits provided the following year. You can see here that more kits were requested in a variety of communities. During these two time periods, kits were requested in 104 of 105 Kansas counties. The need for naloxone is everywhere. Occasionally, we receive a personal note from someone impacted by our naloxone program. This note came from Captain Richard Harris of the Kansas City, Kansas Police Department, and I'll just take a minute to read it since it's a little small. We have used your program to issue a single 4 milligram dose to each officer on the Kansas City, Kansas Police Department. On Friday, that paid off. We had an officer exposed to fentanyl and essentially overdose. Officers on the scene were able to access their Narcan and administer it to him. This saved his life. Thank you for what you're doing. Without this program, we would be planning an officer's funeral instead. Instead, we are writing up officers for saving a life. Forever grateful, Captain Richard Harris. This was also featured on WIBW out of Topeka. They actually had to use 5 rounds of Narcan to revive this officer. So Captain Harris mentioned fentanyl in his note. This graphic demonstrates how little fentanyl is needed to kill someone and why it is critical that we raise awareness about the dangers associated with it and the harm reduction tools available. Now, some of you may be questioning the value of naloxone. Why would we revive someone that may have ingested drugs intentionally? There are lots of stigma around drug use. Relapse reoccurrence does not have to be a part of recovery, and many people move into recovery without it. However, drug addiction is a chronic illness, and like many other chronic illnesses, there's a reoccurrence rate. This rate is comparable to hypertension, asthma, and even type 1 diabetes. When someone relapses with diabetes or high blood pressure, we don't generally place judgment or treat them negatively. However, drug relapse is often treated differently. We want to offer both compassion and information about preventing overdose. Data shows that individuals leaving treatment are at a higher risk of overdose, and it is important to be aware and be prepared to act. Let's dive into fentanyl a bit more. Fentanyl is dominating the opioid and stimulant supply. Individuals may think they're using one substance only to have it laced with fentanyl, causing unintentional ingestion. There are numerous stories about fatal, unintentional overdoses that are destroying families. Naloxone is one tool that can be used to save lives. Fentanyl test strips are another inexpensive harm reduction tool. Fentanyl test strips are a tool that provides information to people who use drugs that they deserve to know. As mentioned earlier, in this age of unstable supply, it is crucial that individuals have information about what is in drugs they are about to ingest. Fentanyl test strips do not tell you how much fentanyl is present, simply if it contains fentanyl or not. The accuracy of the strips also depends heavily on if they are used correctly or not. This is especially critical when you think about things like methamphetamine ingestion or marijuana, something where you're not expecting to get fentanyl. This is where fentanyl test strips can really play a critical role with that. When fentanyl is added to stimulants or other drugs, we often hear about a chocolate chip cookie effect. Yeah, I think there we go, yeah. So think about a chocolate chip cookie. You know, some bites contain a lot of chocolate chips, other bites not so much. This graphic illustrates this effect of how fake pills laced with fentanyl can be extremely dangerous. One part of the pill may have no effect, the other part may kill you. And I don't know if any of you are familiar with a student out of the Mill Valley School District. It was a 16-year-old. He and 3 friends got 2 pills that they thought were oxycodone, got them out of Snapchat, off the internet. The boys split the pills in half. They each took half a pill. 3 lived and 1 student died. So it just shows the uncertainty of what you're going to get. I do want to highlight some limitations with fentanyl test strips. I want to be clear that they're not foolproof, but they're just another tool in the harm reduction toolkit. Individuals inherently deserve services that promote health, regardless of whether they use drugs. Evidence-based harm reduction strategies minimize negative consequences of drug use. And these activities further expand access to harm reduction interventions and better integrate harm reduction into general medical care. To bring everything together I've shared, I'd like to highlight that prevention activities are a critical piece of the continuum of care. We often spend a lot of time and resources on treatment and recovery. These are very important pieces. However, costs and lives can be saved by investing in prevention. Let's just highlight what the various pieces of this prevention continuum mean. Universal prevention refers to interventions delivered to the general population without differentiating between persons at different risk levels. Selective prevention is more targeted than universal, and these interventions should be directed towards populations identified as having a potential to somewhat greater than the general population for developing the focal problem. So a selective intervention might be children of alcoholics. They're at a higher propensity for addiction because they have an alcoholic parent. Indicated prevention is even more targeted, delivering to population groups of individuals exhibiting or expressing warning signs foreshadowing development of the focal problem. So these might be your young people who are experimenting with substances. Maybe there's different interventions for them as well. When we get upstream and fund prevention well, we see better outcomes for children, youth, and families. We see lower incidents of child abuse and neglect, less criminal behavior, better educational outcomes, and less burden on our substance abuse and mental health treatment services. Further, investments in prevention programs would save states and local governments $1.3 billion, including $1 billion in educational costs within 2 years. Greater investment in prevention programs would reduce costs related to substance use, such as medical care and lost productivity, by $33.5 billion, and would preserve the quality of life over a lifetime valued at $65 billion. Now, you certainly can't put a dollar value on the losses that families have suffered due to addiction and the overdose crisis. A life lost to overdose is irreplaceable, and the cost to happiness, success, and well-being of those living with addiction are overwhelming. While investment in prevention doesn't show immediate returns, playing the long game and investing in prevention interventions can save lives and dollars. So thank you for your time today, and I'm happy to answer any questions you may have.
Thank you. Committee questions? Representative Barth.
Thank you, Madam Chair. Thank you for the overview and presentation. I appreciate what you just shared with us. So a lot of terms are new to us, and DCCA, I didn't see the definition in our term book even, so I was looking for that. Can you please tell all of us what that stands for exactly?
So it's actually DECA. The initials actually don't stand for anything anymore. I know it's a little awkward. I know. So in 1974, we were actually founded as the Douglas County Citizens Committee on Alcoholism, focused just in Douglas County, focused just on alcohol. By 1978, we had some statewide contracts. And so in 1988, our board just chose to just become DECA Incorporated. So our initials no longer have any specific meaning. But we are a nonprofit social service agency. We do substance abuse prevention and treatment, child welfare services, including family preservation, and then we also are a child placing agency. We also do some traffic safety work, providing services in Kansas, Oklahoma, Iowa, and Missouri as well.
Okay. I live in Douglas County, so I've seen that around.
Okay.
But that's also all over the state, not just specific to Douglas County?
That's correct.
That is? Okay.
Yes.
You talked a lot about root cause, which I think is important. A lot of things is not Band-Aiding, but also really finding and addressing the root cause of problems. I'm just curious as some of the things that you're doing. I know when I was a child, I grew up in the 80s, and so we had the, just say no to drugs with the, Nancy Reagan. That was something that stuck with me. I still remember that today, and it seemed to be fairly effective to some extent. I just wonder what kind of things you're doing around that specifically, because I think it starts young with children as well.
Yep, I 100% agree with you. We do a lot of work with youth prevention coalitions, and I probably should have highlighted them a little bit more as well. And I'll speak just to our Douglas County work with youth prevention coalitions. They've had a lot of great success. They have a group called Youth Empowered in Prevention. And basically, it consists of all middle school and high school students or buildings in the county. They do a lot of different activities around that. We're actually taking a group of students from the Lawrence College and Career Academy to Washington with us next week to receive an award for the work that the coalition has done. We do a lot of training for youth coalitions, and really it's about empowering the youth to do the work and just to help them recognize like social norms. Just because you may hear that everyone is doing something, that's not actually the case. So really trying to empower and inform students about what's actually happening and what's real. And then giving them information. Kids are smart, and if you give them good information, they'll make good choices. They also experiment, and so we have to teach them about the dangers associated with experimentation. And this also comes with parents as well, and educating parents with some of these pieces. We're actually doing a presentation in Douglas County at the end of the month at the library, just kind of raising awareness about the issues of fentanyl because it's in the drug supply right now. And if kids especially, and I think about the student in Mill Valley, they thought they were getting one thing and they got something else. And kids, they feel immortal. They feel like it won't happen to them.
Well, that story you shared was really what led me to just say no. I mean, what you're talking about is pretty complex, and across the board, I feel like a simplistic, messaging might be something to consider as well. So just my thoughts on that.
And there are early childhood initiatives. There's some groups across the state who are implementing a program called Reward and Remind, and this is an evidence-based early intervention program that is really about behavior management and some of those skills that really does translate to decreased suicide rates among youth, decreased substance use among youth as well. So there's lots of evidence-based interventions that can be implemented for sure.
Thank you very much. Appreciate it. Thank you.
Thank you.
Representative Ellis.
Thank you, Madam Chairman. Narcan.
Narcan.
Do you know how many of our schools have that?
We actually just got a request from KSDE last week to ask if we could equip all of their schools. They were not certain that every school building would want it, but he wasn't sure, and he estimated that anywhere between 1,000 and 1,500 units would be needed for the schools that might request it. We do get some requests from schools, and we're actually working with a couple schools, I want to say around the Wichita area, but I'm not 100% sure on naloxone policy and what that means to have that in their building. And so we do have some schools, and I'd be happy to get some more information to you about how many schools we've actually provided kits to.
It would be very imperative because I hire high school kids during the summer, and I hear more things than most adults.
Yeah.
And that's very needed.
Yes, very much.
Thank you, Madam Chairman.
Representative Burkamp.
Thank you. What's included in the naloxone kit? Is it like a one-time use, or is it multiple?
Sure. So a
uses?
naloxone kit contains 2 4 milligram doses of naloxone. So basically the image that showed the Narcan, it's 2 of those little nasal inhalers is essentially what a kit comes with. When we send our kits out, we also provide education on accessing treatment services through the SAMHSA treatment locator, and then also a resource on signs of what an opioid overdose looks like and steps to move through that, including calling 911.
Thank you.
Committee, further questions? Representative Clifford.
Madam Chair, just a point, thank you. I wonder if we might ought to start using the term fentanyl poisoning, because, you know, it's murder when you think about it, but I've tried to change the language because words matter, and you're right, there's some shaming to overdose or, you know, things that happen to people that are addicted, but I would think that conversation ought to occur and use the word poisoning. Thank you,
Yes.
Madam Chair.
Yeah, very much agree with your terminology as well, because people aren't ingesting the fentanyl intentionally. And so, yeah, absolutely.
Representative Haswood.
Thank you, Madam Chair. Do we have data on which black market product, is it pills, is it cannabis, that folks are being poisoned with?
It's really everything. When we talk to our law enforcement partners, there's really not a drug. If you get a drug, assume there's fentanyl in it, is the kind of the recommendation people have been providing. Basically, we look at, we get some data from the Midwest HIDA on overdose spikes per se, and so that's one way that we can tell if maybe there's a bad batch of a drug out there, but it's in everything.
Thank you.
Committee, further questions? I've got one, because I know how because when the test strips got brought up last session, so I kind of did some research and learned how do you test a pill?
Right.
But how do you test marijuana?
It would depend on how it comes, whether it's a dab, an edible. It would just depend on the method. We looked at, Missouri's doing a lot of research right now and implementation on fentanyl test strips, and they're using a company called DanceSafe for their fentanyl test strips, and so there's a wide variety of directions, I guess, on how to test any given substance, and so I certainly don't have expertise on how you would test each substance, but that would be a good resource for identifying how that might happen.
Okay. Well, and I think that the chocolate chip photo you've given us here explains a lot, because, we had an incident here in the last several months, and it struck me when the mother said, well, he'd done a half of that pill the day before.
Right.
And so I'm going through my mind thinking, well, Mom, maybe you shouldn't have let him do that. But two was, how did a half and then not? So now this makes sense.
Right. Yeah, it's very scary. And that's one of the things with fentanyl test strips. You would have to crush your pill, and there's, crush your pill, add some water, and then evaporate the water, and then ingest your pill at that point. But at least that's one more tool to inform people. I'd like to think if I have the option to know what I'm putting in my body, I might try that, unless I'm trying to intentionally ingest fentanyl, and that can be a challenge in and of itself.
Right. Well, now you just said evaporate, so you wouldn't do the test with the water and just drink it?
You can do that.
Okay, all right.
But if it's an injectable or something you smoke, then
I see.
sometimes they will allow the water to evaporate and then inject or snort.
It's a lot of time to.
It is.
Yeah, I guess when you don't use it, it's just hard for us sometimes to fathom what's going on out here. But this is a very powerful chart, so
Thank you.
we need to see that a little bit more often. Committee, are there any other further questions? Representative Berquist.
Thank you, Madam Chair. Two questions. Narcan, is it aerosol or injected?
We provide the aerosol, so it's a nasal spray. So much like if you have seasonal allergies and use a nose spray, same idea. There is injectable naloxone that EMS will use occasionally. Injectable is cheaper, but people are uncomfortable. General public is not super comfortable putting a needle in someone. And so this is nose spray, easy to administer, pretty foolproof.
A follow-up, if I could, Madam Chair. Then if there's two of those in a Narcan kit, does that mean only two persons can be treated? Because it would be personalized by being used in the mouth, aerosol.
So typically what we're seeing with fentanyl in the drug supply, typically one kit is being used to revive one person. So they're using both nasal sprays to revive one person.
Okay.
The officer in Kansas City, they had to use five doses of naloxone to revive him. So basically our goal is to allow people to administer that so 911 can get there, EMS can get there, and then administer more and implement other measures.
Thank you, ma'am, and thank you, Madam Chair.
Okay, now you've raised another question for me on this doses issue. So you can't basically have a major issue with possibly with too many doses of it?
No,
Okay.
not at all. There is no research that shows an overdose on Narcan. Perfectly safe. I would be comfortable shooting it up my nose right now if I had a kit, but that would be a big waste.
Right, okay.
But it would not hurt me.
Okay. Committee, are there any other questions for, yes, Representative Gardner?
Thank you, Madam Chair. I'm pretty naive to this whole business, and so my question would be, do we have any ideas about why this is coming down the pipeline? And I'm sure there's some cost involved with producing this stuff and some motivation for distributing this way. Do we have any clue about that so that there could be at some point some way of controlling the pipeline on this stuff?
Sure. Fentanyl is very, very addictive. It produces an incredibly powerful high if it doesn't kill you. And so that's why drug dealers will try to add that to their products, because it will get more people addicted to their product and they'll keep coming back. And so that's why people are putting fentanyl in the drug supply, just due to the addictive nature of it. It's kind of like, this is, the drug trends across the country. They always kind of start on the coast and move in. Basically, that's what we're seeing right now. This was trending, probably 10 years ago on the east and west coast, and now it's coming in and really starting to impact us as well. But really just the fentanyl being highly addictive is why people are putting it in the drug supply. And if they kill a customer or two, then I think that's the cost drug dealers are willing to accept.
Okay. Well, and you don't, and each individual, and correct me here if I'm wrong, but each individual has no idea how much fentanyl that their body can handle.
No.
And that's the other big deal, because, and if you'll perhaps explain to the committee, what is fentanyl's original purpose?
Sure. Fentanyl is a pain reliever. My daughter broke her arm last year and had surgery. And after surgery, we went up in the room and they're talking about, well, we've given her this much fentanyl. And I started to panic, and then I'm like, okay, these are doctors at Children's Mercy. They're not going to overdose my kid. But it's a pain reliever. It's a very effective pain reliever as well.
Yeah, because that's what I was just asking Dr. Epley, because it can also be used, and a lot of times it is, during anesthesia.
Yes, anesthesia, yeah. Mm-hmm.
Yeah. Because we've had people, ask before, well, why don't we just get rid of it? Well, no, because it's got a purpose.
Right.
In the medical field, so we can't get rid of it. It's just the bad guys getting hold of it.
Yes.
Representative Bryce.
Thank you, Madam Chair. Thank you for that report. It's very, very interesting. In my day job, I work in emergency departments, and I just wanted to clear up, maybe there was a question about 2 doses in 1 pack. I know that fentanyl has a longer half-life than the naloxone, so a lot of times it's not 2 different patients you're planning to treat, but before the EMS can get the patient stabilized, the naloxone wears off and you get a second dose. So sometimes you have to give multiple doses because the opiate itself is a longer half-life. I hope that's helpful. Thank you.
Yep, no, that's a great point. And there is an 8 milligram naloxone called Cloxado that we've looked at using. There's been a little resistance from using the 8 milligram just because it is more, it will pull you out of the overdose more quickly, and we've been told it's more painful, I guess, if you're, it takes you out of your high quickly or more quickly.
Representative Reese.
Can you talk a little bit more about just the exposure to it, like EMS, police officers?
Sure. I wish I would have put a video in here because that would have shown the police officer who was exposed. What it appears on the video is that he had the drug product on his hand and he breathed it in is what it looked like. And so, I'm not certain about, every EMS incident that may experience an overdose, but just that unintentional ingestion is how we've seen it occur anyway.
Yeah, I've heard a lot of people talk about just, the risk that we our first responders are put in,
Yes.
because of that, because it's an easy exposure.
Yes, absolutely. And that's why we especially prioritize our first responders. We actually received some new dollars from KDADS called FR CARA, which is specifically providing naloxone to our first responders in 4 of the 6 EMS regions. So that's one tool that we're trying to get out to first responders especially.
Thank you.
Committee, further questions? All right, seeing none, thank you very much for being here today. We appreciate it, and I'm going to use this chart, so.
Thank you. I'm happy to give you other graphics as needed as well.
All right,
So
thank you.
appreciate it.
All right, committee, now we have Community Care Network of Kansas. We have Sonia Bacchus, CEO of Community Care Network of Kansas. Welcome to committee.
Good afternoon, Madam Chair Landwehr, Vice Chair Epley, Ranking Minority Representative Ruiz, and House Health and Human Services Committee. As Madam Chair stated, I'm Sonia Bacchus. I'm the Chief Executive Officer of Community Care Network of Kansas. And on behalf of our members, we thank you so very much for this opportunity to share this informational presentation with you today. So first, we'll share who we are as an association. We are the State Association of Community-Based Primary Care Clinics. Our members are dedicated to providing equitable access to health care for Kansans, all Kansans. We have 32 member clinics. These member clinics provide primary care services to our patients regardless of ability to pay, and I believe you know that how critical that is for some of our patients. In 2022, more than 332,000 unique patients received care in more than 1 million visits to our clinics. There are 3 types of our member clinics. 19 are federally qualified health centers, or FQHCs, and we'll have some acronyms which are included in one of your handouts with our acronyms and definitions. We have 3 FQHC lookalikes, and then we also have 10 community-based clinics. In 2021, UDS data showed FQHCs alone provided over $38 million in sliding fee discounts. These 3 clinics will be discussed a little more on the next slide that we just moved to. Key features of federally qualified health centers, or FQHCs, are that we are organized under Section 330 of the Public Health Services Act. We're designated by the Federal Bureau of Public Health Primary Health Care, or BPHC, to serve high-need areas. We are community-led organizations and meet rigorous federal board composition requirements. There's a federal allocation to help the cost of care, and we receive prospective payment system, or PPS, reimbursement for both Medicaid and Medicare patients. All of our organizations offer some type of sliding fee scale for self-pay patients, and these organizations are also able to purchase discounted drugs under the 340B program. The key features of FQHC lookalikes are that they must meet the same requirements as FQHCs and are entitled to all FQHC benefits except Section 330 funding. That Section 330 funding can come into play once new access point or expansion grants are put out by the Bureau. Key features of our community-based clinics are they do not have any federal designation and all provide services regardless of ability to pay. And some of them are almost completely free of charge. I was visiting one a couple of months ago, and the only area that they charge their patients for is for labs because they have to send them out externally. If you look at the map that we've provided, you see that our member clinics provide services throughout the state. Our clinics, again, accept patients no matter where they live. Some come from out of their actual primary service area, and most clinics do have patients who come from a multi-county area. Kansans from almost every county visited one of our member clinics in 2022. Our payer mix reflects our commitment to access to care. So our payer mix, with the highest payer mix being Medicaid and CHIP at nearly 31%, Private insurance, around 29%. Uninsured, around 29%. Medicare, close to 11%. And then other types of public funding are less than 1%. In 2021, and this is significant, FQHCs and lookalikes wrote off more than $50 million in sliding fee discounts and bad debt. Our clinics also provide millions of dollars worth of important services that go unreimbursed by payers, to include care coordination and community health workers. This doesn't provide us quite a complete picture, because almost every clinic provides other services that complement the care that they provide, and payers do not typically pay for them. Some of these services include translation, care coordination, transportation, food pantries, and many other types of services. How do our clinics cover these unreimbursed costs? For the FQHCs, there's some Section 330 funding, which is generally a fairly small part of the overall budget for each health center. There's community-based primary care clinic funding, which we are appreciative of through our state, that's appropriated annually by the legislature and awarded through KDHE. And in 2022, that number was approximately $9 million. We also have the benefit of 340B savings, which is included for FQHCs and our lookalikes. And those savings are passed on to patients in the form of free or significantly reduced costs for prescriptions. And then health centers are allowed to bill our insurers for the full cost of the drugs and reinvest those savings in services to patients. The important thing to remember about 340B is that FQHCs and lookalikes are required by the federal government to ensure that each of those dollars is reinvested in either new services or expansion of services in those organizations. And so there's very stringent oversight of the 340B program for FQHCs and lookalikes. The types of care provided by our member clinics include medical care at almost 710,000 in 2021, nearly 69% of all visits. There's dental care provided as well, close to 187,000 dental visits for about 18% of all visits. Some of our health centers even have vision services and employ optometrists and/or ophthalmologists in their locations or in partnerships at about 1%. And then behavioral health for nearly 104,000 visits, which equals about 10% of total visits. While our members are generally thought of only from a medical primary care standpoint, other types of care are significant parts of what we do, and behavioral health in particular continues to grow as clinics move to integrated models of care. Specific to integrated models of care, research shows that addressing physical and mental health needs at the same time improves outcomes. Both primary care clinics and mental health centers are moving to integrate mental and physical health care. Health centers increasingly are integrating behavioral health into primary care, and the CCBHC model that you all know well is also a integrated care is also a central feature of the CCBHC model. Just know that our members are integral parts of the mental health system in Kansas. One of the ways that we are partnering to learn more about integration of care and to work closer with our community mental health centers and the CCBHCs is the Delta Center for Thriving Safety Net grant that we received a couple of years ago. This is a partnership involving both mental health centers, community health centers, and our state associations. This group has been pursuing policy, payment, and practice changes to advance integration in both mental health centers and FQHCs. The progress to date of this partnership is a better understanding of each model and challenges each type of organization faces. There's exploration of care coordination, encouragement of local dialogues and partnerships, and then shared data collection as a way of documenting the outcomes of the integration work being done in each type of health center. Our work has helped us to find new ways to work together as association and start the conversation on facilitating partnerships at the local level. There are some challenges that face our network of members. The number one challenge that we hear is workforce. What was really interesting is in October when we had our annual conference, our CFO forum listed workforce as the primary issue that they see as CFOs. That's not normally what CFOs are talking about. CFOs are normally talking about saving money and doing better at billing, and the number one conversation was around workforce. Our executive team visited about 60% of our health centers over the last several months as I got to know the organization and all of our members, and workforce and challenges around workforce, which include being able to get staff recruited and providers, so the pipeline of the workforce. And then once you can recruit, then you've got to be able to afford them with the increases in salaries that have been requested across the country, but certainly here in Kansas as well. And the third part of that has been the child care options that are available or lack of availability of child care. So workforce is a huge challenge, as it is with many industries and our other healthcare partners in Kansas. 340B is another challenge. There are many threats to 340B from different areas. And there are some federal and state remedies and legislation that we believe would be important to further the interests of our health centers in terms of how 340B is protected so that we can continue to take care of our patients. Capital needs are another area that our health centers are facing challenges. Many of our health centers could and would do more work if they could update and or expand their current health centers, if they could build larger locations so that they can provide more services. And then some of our buildings are just getting older and need additional repairs and renovation. So those are some of our primary needs and areas that we will be seeking support from the legislature this year. Again, on behalf of our member health centers and clinics, we thank you for this opportunity, and we're open for questions.
Thank you. Committee questions? Representative Clifford and then Representative Haswood.
Thank you, Madam Chair. In Finney County, previously our FQHC was called United American Methodist Ministries Clinic, and migrated now to Genesis. Is there still a church affiliation with any of your members, or did that go away with the federal funding piece?
Actually, there are several of our members who are faith-based organization. Grace Med out of Wichita, Mercy and Truth Medical Missions, who just became a FQHC lookalike. And one of the pieces of actual technical assistance that I have been working to provide is to connect our members in Kansas who are faith-based organizations, particularly Mercy and Truth, as they make that transition to other faith-based organizations so that they can continue to operate in that manner. And so it is allowed for FQHCs.
And a follow-up, just our FQHC, I mean, if somebody comes in with COVID, they go to the house to test everybody else. I mean, your organization does great outreach, and then if they notice there aren't enough blankets for the kids, they find blankets for the kids. So I really appreciate what you do. Thank you, Madam Chair.
Representative Haswood.
Thank you, Madam Chairwoman. What would the cost savings be for you all if the Kansas Legislature expanded Medicaid?
I believe the number is about $58 million annually.
Representative Reese.
Thank you for the presentation, and thank you for talking about the integrated care model that you're looking at. Is there work with any of the universities that have clinical social workers that may be being able to do a practicum within the clinics? I mean, part of that is assuming that there's a social worker that can, be the practicum advisor. But is there, do we have any helps with that?
Yes, ma'am. Thank you for that question. A number of our health centers and community-based clinics are teaching organizations and provide education opportunities and preceptorships for medical and behavioral health providers. Yes.
One more. And then one more question in addition to that, what about public health workers, people that are maybe getting their master's in public health? Is there an avenue for them to have a practicum there?
It depends on the health center and their ability to do so. But I can tell you, as a former FQHC CEO, I certainly did allow both clinical and non-clinical opportunities. And so our health centers are great learning organizations. And so I don't know any specific. We're happy to look for, find that out and get that information back to you. But most of our health centers do allow for students to get education there.
Wonderful, thank you.
Committee, any further questions? Representative Barth.
Thank you, Madam Chair. Thank you for the presentation as well, Sonia. And I saw you come off the elevator there with those shoes. They're fabulous. If y'all haven't seen them, check them out. So I was a fashion major, but my background has actually been in the advanced primary care health center services here, as well as some other areas. And so I'm kind of curious, you brought up the number of visits for medical, and I didn't realize you did as much in the dental and vision space as well. But do you have a breakdown of information of how much you do from a services standpoint on acute care versus chronic disease management care as well?
I don't have it here with me today, but we can get that to you.
Okay, and then another question I have too is just, so I've done a lot of employer-sponsored care, not community-based, and so one of the things that is looked at is risk stratification and in targeting those folks that are higher and more moderate risk folks. Those are actually the folks that typically are more the higher cost claims types of folks that are more than likely to create some sort of event if they're not following their care guidelines, and there's gaps in care, then they're more likely to end up in a hospitalization or some sort of emergency care needs, which often are going to drive costs even higher up. And that's something that is a concern with taxpayer dollars being utilized, and how do we provide the better care so they're just happier, more productive people in general. Do we track anything? I know Representative Clifford mentioned something about outreach, but are we looking at chronic care management for this population as well, where we're trying to help better manage that?
Absolutely. So there are a number of ways that that's being done among our members. One of them is a number of our members are participants of accountable care organizations, or ACOs. And so those organizations, obviously, part of what the work that they do is to really manage their covered lives and manage that health status of those covered lives, with that having cost savings so that they can get some of those cost savings back to provide more care. And so we have a number of members who are a member of ACOs. We have members who have patients in the One Care Kansas program, which is the program for those with a behavioral health and a chronic disease. And so we have a number of members in that program. And then we also have a health center controlled network. And from that health center controlled network, we use a system called Azara Drives. That system allows our health centers to, on a daily basis, review and manage care gaps and areas where patients need more care. And so that system, it provides tons of data and tons of information and significant information, particularly around chronic disease, that allows those patients to be managed. We're also in the process of looking at how we band together as a clinically integrated network to further the opportunities to be able to, for that risk stratification and really being able to take care of those patients better.
Okay, that helps. Thank you.
Representative Epley.
Thank you, Madam Chair, and appreciate your presentation today. It's been really helpful. I come from a community where we formed a free health clinic, and over time it evolved into an FQHC. And I'm all about competition up to a point, but in some cases I've seen situations, at least in bordering counties in urban Kansas where the FQHCs can become somewhat of a competitor with small rural hospitals. And I look at your payer mix, and it doesn't look that much different than payer mixes for some of these small rural hospitals that do write off a lot of bad debt and so forth. And I'm curious, how would you respond, or how would you distinguish FQHCs from the mission of a small rural hospital or a smaller hospital in an urban area that's trying to survive?
Well, I would say that those organizations actually are very much alike. We serve a similar patient population. But I think that and I've been in this situation before, so what I encourage of our members is to work to partner, because there's always going to be some things that one or the other is better at. And we see large hospital systems across the country finding ways to partner and to provide services in ways that they are, that those who are specialists in one area are able to provide those services. And I think that if we work together, instead of competing as much and be more collaborative, then we can serve more patients and we can serve them better. So that's the encourager that I have. And there are some areas that have, fewer patients and fewer residents. But in most cases, there's areas for collaboration if they'll work together.
Thank you for that answer. Thank you, Madam Chair.
Representative Clifford.
Thank you, Madam Chair. Thanks again, Ms. Bacchus, for the presentation. I always worry when I hear talk about 340B being in jeopardy. I don't know if that's because of abuse by large health systems, or, is it a federal threat, a state threat? I mean, I have 5 hospitals and FQHC and 340B, and we really need to keep it. So what are the threats? Thank you.
So the threats are really a couple of areas. The pharmaceutical companies, some of the pharmaceutical companies, not all, but some, work to limit the FQHCs from being able to use contract pharmacies, or covered entities from being able to use contract pharmacies. I think the intention probably is good, and it gets though FQHCs and community health providers a little bit caught up in that process. Some FQHCs are not in a position to open their own in-house pharmacies, and those that can't, or they may be in areas that there is a strong pharmacy within, strong local pharmacy within the area, so it doesn't make sense for them to open a new pharmacy and eat away at that local economy the way that's already there. And so I think that we have to keep contract pharmacies viable. Those relationships have to stay viable. And then pharmacy benefit managers who also, by the way that they contract and some of the tactics that they use, do cut away at those, at the savings that go back to the FQHC. So it's a critical program for FQHCs.
Madam Chair. So are the PBMs actually clawing back from the FQHCs, the 340B programs?
In some cases, they are clawing back. In some cases, there are some issues there.
Thank you for your answers. Thank you, Madam Chair.
Yes, sir.
Committee, are there further questions?
I have one.
Representative Reese.
Another question. What kind of funding do you have to help for interpreters or translation services?
So those types of services generally, unless there's some specific grant funding for those services, and those services are required for FQHCs within the program requirements, unless there's specific grant funding for those programs, those are the types of things that get funded out of 340B and or 330 funding.
Okay. Has a cost analysis been done? How much revenue is being lost because of the lack of funding?
I am not sure on that, but I can definitely work with our team to get any data that we have available to you.
Thank you.
Representative Epley.
Thank you, Madam Chair. I'm again looking at some of your threats or concerns going forward. I know that a lot of the FQHCs do live from grant to grant sometimes, and are these grants, I'm trying to understand, are they ongoing, or is there competition for the grants, or how does it each, because I know each FQHC doesn't always qualify for the same amount of grant money from the federal government. Give us a little more information on how that works and whether that's ongoing and sustainable or not.
So
Thank you very much.
Yes,
Thank you, Madam
sir.
Chair.
Thank you. With respect to the federal grants, those grants are calculated by the service area and the number of patients served in each one of those areas. And then, but outside of the 330 federal grant funding, there are various both public and private grants that are applied for and secured by health centers. And with that, some of them are longer-term grants. Some of them are grants that help provide, for example, maybe a clinician who will generate revenue and be able to sustain the new work that's being done. There are some times that you are competing against FQHCs may end up competing against other FQHCs or even against other providers. And with that, there are chances that, there's funding that can be lost. I've seen an FQHC not get continued funding, for example, for the Ryan White program, and those funds went to another provider. But during the every 3 years, each FQHC has to reapply for their funding. Others can apply for that funding during that time period. It doesn't happen all that often, but it could.
Thanks very much.
Yes,
Thank
sir.
you, Madam Chair.
Committee, further questions? Representative Gardner.
Thank you, Madam Chair. And thank you for your presentation today. I realize my question may not have a real specific answer, but could you give us just some estimation about, as I understand, you were showing us the makeup, about 29% of the people served were uninsured?
Yes.
Is that correct?
Yes, sir.
And that was about the same number of people who were insured.
Yes.
And I assume from presentations we've had in this committee last week that the reimbursement rate for insured people that you serve is higher than the reimbursement rate you get from those that are on Medicaid. Is that correct?
Well, it depends on your contract with your with commercial insurers, and so each one of the FQHCs in particular have a PPS rate, which is set based on their cost annually, and so it could go either way. It just depends on your contracting with your commercial insurers.
So I guess my question was, you'd mentioned that if Medicaid expansion were adopted and raised the level to 138% of the poverty line, that would increase revenue coming into these clinics.
Yes.
But is there any estimation about as you shift more of your insured people now to Medicaid, how much that would reduce revenues because of lower reimbursement?
It would likely not reduce. Again, it depends on what your commercial insurers, your contracts are with each commercial insurers. In general, the Medicaid PPS rate generally is a little bit higher, though.
Thank you very much.
Yes, sir.
Thank you, Madam Chair.
Committee, are there further questions? And I think one of the things to distinguish from some of the organizations that bill Medicaid, as you heard her say, is that they're on a cost basis, just like our new CCBHCs are on a cost basis versus the Medicaid rate, which is down here. And that makes a big difference. And then they also have the ability to build CHIP as well. And I don't know about across the state, but I know like a lot of them, the Grace Meds in Wichita are actually attached to school buildings. the clinics are. Any further questions, committee? All right, seeing none, thank you very much. Appreciate you being here today.
Thank you.
Okay, committee, that concludes everything for today. We do have committee 1:30 tomorrow, so we are adjourned until 1:30